everyone. Let me present myself. I'm Dr. Bhuvanesh Xray, Neurology Registrar at Gutus Care Hospital. I would like to thank Dr. Suzanne Murray for giving me the opportunity to present today. So I'll be presenting an interesting case of myelopathy. Let's start with the history. A 24-year-old male patient, previously well, presented to the local clinic in March with right upper back pain of 1 week duration. He was given painkillers and was told that the pain was muscular in origin. Then in June 2021, he complained of numbness on the inner side of his left leg, followed by pain in his left knee. He then started limping. In July, his left leg became weak, followed by right leg weakness after a few days. He had to hold onto furniture and walls to mobilize. Over 1 month, he was unable to walk and felt numbness in both limbs. He lost control over his bladder and bowel functions. In August, he went to a private hospital in Eastern Cape for evaluation, but could not afford further investigations. In October, his right foot was swollen. He then applied a hot water bottle to reduce the swelling and sustained a burn. So this is a picture showing the burn injury to the right foot. So there were no constitutional symptoms, no history of trauma to the back. The upper limbs were normal. There were no visual or bulbar symptoms. On examination, the vitals were normal. There were no jaundice and lymphadenopathy on general examination. Cardiovascular and respiratory system were unremarkable. The abdominal examination showed no hepatomegaly and no right upper quadrant tenderness. On motor examination, the upper limbs were completely normal, but the lower limbs showed spastic paraplegia. Sensory examination showed T5 sensory level to pinprick and light touch, with no sacral sparing, with loss of joint position sensation up to the knees. Examination of the vertebral column showed no gibbous, but tender spinous process in upper thoracic spine. Coordination was normal. The rectum examination showed reduced anal sphincter tone. The basic bloods we did, so the white blood cells were 8.45, hemoglobin was normal, he was HIV negative, syphilis negative, the liver enzyme slightly elevated ALT of 49 and AST 24, but the ESR and CRP were markedly elevated. So in summary, it's a 24 years old male patient with no comorbidities, conditionally well, first presented with upper back pain, followed by subacute progressive weakness in the lower limbs with T5 sensory level, with bowel and bladder involvement. So my clinical impression was a myelopathy. So I ordered an X-ray whole spine, but the X-ray was a poor quality, which showed disruption of T4 spinous process. The chest X-ray was normal. Then we requested an MRI. This is on the left side, it is a sagittal MRI, T2 sagittal MRI. We can see there's a collection in the epidural space at the level of T2 to T5. And here you can see cystic lesion, white cystic lesion, having same signal as the CSF. And on the axial view, we can see an intraosseous cystic lesion in the vertebral body, and a paravertebral cystic lesion here, and a and they all have a similar signal to the CSF. This is another view, the axial view of a spine, showing the cystic lesion here again, compressing the epidural space, compressing the spinal cord. This is the T1 sagittal MRI. On the left is without contrast, and the right is with contrast. We can see that the cystic lesion does not enhance, and there's a collection at the back of the spinal cord. This is the CT scan, which shows disruption of the spinous process of a T4 vertebra. And I don't know whether you will be seeing a small dark dot here. So it's having the same density as CSF. So this is the intraosseous cystic lesion. And this dark lesion here is the cystic lesion, the paravertebral muscle. So all the images is very consistent of a spinal Hydatid disease. I referred the patient to the neurosurgeon. We did a ultrasound liver to rule out any cystic lesion of the liver. It was normal. We sent a echinococcus antibody ELISA test, which was positive with a titer ratio of 3.0. So the patient went for spinal decompression, but is in laminectomy. So let me say a few words on spinal Hydatid disease. It is an uncommon manifestation caused by the larval stage of Echinococcus granulosus, or less commonly Echinococcus alveolaris, or Echinococcus multilocularis. Coming to the epidemiology, in South Africa, the disease is prevalent in Limpopo, Eastern Cape, Northwest, and Northern Cape province. Retrospective NHLS information system results for serology, microscopy, and histopathology from 8 provinces, excluding KwaZulu-Natal, gave an overall positivity rate in submitting diagnostic samples of 17%, with Eastern Cape leading at 30%, Northwest 19%, and Northern Cape 18%. Studies carried out in South Africa reported an overall prevalence of 9%. The incidence of Hydatid infection in the CNS in endemic areas is 2 to 3%. This is the life cycle of Echinococcus granulosus. The dog is the definitive host harboring the adult worm. The sheep is the intermediate host harboring the larval stage of the tapeworm. And the human being is the accidental intermediate host. So the human being may get infected by eating contaminated food. So while reviewing the history of the patient, I asked the patient, he told me that he used to consume vegetables from his yard, and there's a dog in his yard. So most probably he got infected from that itself. Coming to the pathology, the spinal Hydatid disease is thought to occur via 3 possible mechanisms. First one is hematogenous spread directly to spinal structures, the direct invasion from extraspinal structures, and infection secondary to cerebrospinal fluid seeding due to ruptured cysts of cerebral Hydatid disease. Clinical features, there are no characteristic signs and symptoms, but the usual manifestation are long history of back pain, signs of spinal cord compression. Back pain in 85%, radicular pain in 25 to 95%, and paraparesis and paraplegia in 25 to 70%, but very rarely cauda equina syndrome. Furthermore, rupture of a spinal Hydatid cyst can result in a type 1 hypersensitivity reaction, such as anaphylaxis. Spinal Hydatid disease can be anatomically classified according to the Dew and Lees classification. The type 1 is intramedullary, type 2 intradural extramedullary, type 3 extradural intraspinal, type 4 vertebral, type 5 paravertebral. However, multiple types can also coexist. The serodiagnostic test, the Echinococcus antibody ELISA test, is reported to be 80 to 100% sensitive and 88 to 96% specific in abdominal disease. However, the sensitivity decreases abruptly to 25 to 50% in extrahepatic disease, which limits their use in the diagnosis and or follow-up for primary bone disease. Imaging is more sensitive than serodiagnosis in spinal Hydatid disease. Coming to the treatment, the cornerstone of spinal Hydatid disease management is surgery, the most common procedure being simple decompression with laminectomy. Surgery is often an emergency due to spinal cord compression, either being the presenting feature or being an impending complication. Infiltrative cysts in the vertebral bodies are difficult to remove. Cyst rupture and seeding is common, increasing recurrence risk. Combination therapy with albendazole and praziquantel is effective in the treatment of Hydatid disease and can be used as an alternative to surgery in disseminated and non-operable cases. The prognosis of vertebral Hydatid disease is poor, especially when vertebral symptoms and signs are present. Even with the use of scolicidal agents like hypertonic saline, intraoperative seeding is common, leading to recurrence rates up to 40%. Recurrences occur 2 to 28 months after the initial operation. The high recurrence rate is primarily responsible for poor survival of only 5 years after the onset of symptoms. Operative mortality rates up to 50% are noted in the literature and are known to increase with subsequent operations. So coming back to my patient, so my patient went for surgery. He had a spinal decompression and a laminectomy, and the histopathology report confirmed the diagnosis of spinal Hydatid disease, but unfortunately, post-surgery, he developed weakness in the upper limb also due to a cervical thoracic syrinx, as you can see in the diagram, in the picture. So this is the end of my presentation. Thank you for your attention.
Thanks very much for a lovely presentation, a very nice case, very interesting case, and great neuroimaging. So thanks very much indeed. Perhaps you could put your video on, Dr. Xray, and we could take comments and questions from the audience. But first, perhaps if Suzanne, as a consultant involved in the case, would you like to make some comments?
Yeah, so this was the first time that I've seen spinal Hydatid disease. I've seen it in the cerebrum, but not in the spinal cord or in the spinal canal itself. But maybe, you know, we just don't get referred these patients because they've got bony abnormalities and they are directly referred to orthopedics or neurosurgery. But I thought it was just a good learning case, and we wanted to highlight the prognosis in these patients. That, you know, you might assume that you remove the cyst and everything is well, but apparently they do recur in a substantial proportion of patients. And I don't know if Sally Rothmeyer is on. She said she might be joining. She was involved with the surgery in these patients, and she has more experience with these patients because they do them surgically from time to time. So maybe she can comment. But I just also read an interesting perspective of echinococosis, and I would like to know what you as ID department or division think about it, that echinococosis has been becoming more frequent in or more common in South Africa, and it's postulated that it's because of the high incidence of TB and HIV that modulates the immune response, which might result in decreased innate defense mechanisms to this, because you know, they looked at the NHI. Walers is the author, was the first author of the specific publication, looked at the NHLA's database and saw that there was a significant increase in diagnosis between 2005 and 2009, and they published this in 2013 and said that they're still seeing an increase, you know, frequency of diagnosis. So I don't know what you might think of that. So firstly, Sally, if she's available, then your opinion, and then what Micro think of the diagnostic utility of serology, because also what I've seen from where they compared pathology to serology, that a lot of these cases are missed on serology. So just those three things. Thanks.
Fantastic. Thanks very much. I'm going to, before I ask you to give your question or comment, I'm going to ask Sipo, who is somewhat of an expert on Hydatid, to just give or to address your question, but also just perhaps the discussion around the use of praziquantel in these cases, as well as albendazole, which some controversy about. Sipo, what are your thoughts?
Yeah, no, thanks, Mark, and thanks for presenting this interesting case. So I think the first thing is that I think over a number of years we are picking more cases up, but whether it's because we're getting better at recognizing the disease and the imaging that goes with it is one thing. I think that probably is a role to play. I'm not too sure about the immunological aspects of TB, HIV driving this, because I think for a number of years, it's just been unrecognized. And when you encounter these patients, they've been in the system for a long time and only end up to our centers when things have gone horribly wrong. So for example, in this case, this man's almost inability to walk is what makes him come to your center for further diagnostic workup. So I think there's that challenge and really educating doctors to be aware of this. And certainly the eastern part of our country is where we see lots of these cases. So KZN, Eastern Cape, and I think for us, Eastern Cape is a big drainage area, although there are some local cases that happen here. Just remember, this has got to do with how people practice. A lot of it is cultural, where there's slaughtering of animals and that dogs are present, and that, offal is not discarded appropriately, and there's that interaction. The only way to prevent this, of course, is also through vaccinating dogs. I think there's that aspect, but how well that is done in this country is another story, because you can imagine from the rabies perspective, we're not very good at that. Coming to treatment, I think the treatment is difficult because you're not going to get any randomized controlled trials on this. So albendazole is the go-to therapy of choice. Praziquantel has been looked at, but it's usually in combination with albendazole and is said to be useful peri-surgery. So a day or two before surgery, and then you do the surgical incision because, and then you probably stop. And you might then continue with albendazole. The difficulty, and as you indicated, is that there is a high relapse rate in this condition. And the question is, how long do you give albendazole therapy for? Now, albendazole is not without its toxicities, especially related to the liver. Some suggestion is you're probably looking at 3 to 6 months after surgery, and then stopping, and then having close follow-up of these patients. And I've certainly been involved in cases with the orthopedic surgeons where they've done as much evacuation of the cysts as possible. Patient is given 6 months therapy, and a year down the line, they come back again with what are obvious hydatid cysts. So very difficult, and very unfortunately, these patients are probably not looked after because there's probably no centers of excellence where we are studying this problem and really helping patients. So difficult in terms of duration of therapy for albendazole. I think some patients probably end up needing it lifelong. Very difficult to judge who. Most likely the ones where you can't do surgery, you're probably looking at very long treatment courses. Those you do surgery, I think 3 months to 6 months of therapy is fair, and then stopping, and then close monitoring and see and reacting once new lesions pop up.
Thanks, Sipo. Very, very nice comments. Thank you. So, Adrian, perhaps in addition to whatever your comment is, if you could answer Suzanne's question about the serology. Thanks.
I'm actually going to, if you don't mind, refer this question to Hafsa, because she just published with James a case in a child at Red Cross Hospital, very similar. This was from a rural sheep community, farming community near Beaufort West, I think. Hafsa, I know you're a bit shy, but maybe you should put on your camera and respond. The comments, the way that Dr. Raj's case report and Hafsa's one is very similar. Thanks, Hafsa.
Thanks, Adrian. Thanks, Hafsa. Over to you.
Hello, everyone. Yes, so we also had a case at Red Cross, but ours wasn't in the spine, it was in the brain. And the serology in our case was negative, and when we looked at the literature, that's not unsurprising that the serology can be negative because it's in a pristine, protected site from the immune system. So for these cases that present with lesions in the central nervous system, negative serology does not exclude it, and unfortunately the only way to prove a suspicion on radiology and also then to biopsy it and send it for wet microscopy to look for hooklets, and also on histopathology as well, autogens. In terms of the treatment, I agree completely with Sipho that it's combination therapy in the beginning, especially because there was a recent meta-analysis that was published that showed that the number and size of cysts definitely decreased with combination therapy. However, most of these studies in the meta-analysis was from lesions within the liver or the lungs. But having said that, seeing that the site of infection in the central nervous system it's such a precious site, and if you don't treat it adequately, the outcomes can be quite devastating. I think it's fair enough to say that you should extrapolate from that literature and treat with combination therapy. But as Sipho mentioned, duration is very difficult to say.
And how long did you, Hafsa, how long did you decide to treat this brain hydatid?
Our case is still relatively new and fresh, so I don't think she's completed 6 months of therapy yet. And she had quite extensive lesions. So unfortunately, in our case, she presented with seizures, 11-year-old girl who presented with seizures, and because she was from a rural area and it happened during COVID, they could not access neuroimaging until she presented with raised intracranial pressure, and by then she had extensive lesions with neurological fallout. So we're going to go for a bit longer.
No, thanks very much. So Suzanne, I don't think we've adequately addressed your main question around the HIV TB. I also not sure. I mean, I don't know if anybody else has input to give on that. Perhaps you could circulate that paper. It would be very useful to have a look at, and then maybe we can have a further discussion. Any of your neurology colleagues that are with Dr. Xray and at the Neurosciences Institute, would you like to make any comments, or we're close to the top of the hour, but if there are any further comments, Dr. Xray, do you want to sum up?
The combination of albendazole and praziquantel mainly acts on adult worms, and it's written in the literature that praziquantel increases the absorption of albendazole. So this is why the combination is good and increases the efficacy. And the treatment normally it's for 6 months. In some literature, it's written 1 year. Yeah.
Okay, thanks very much. So if there are no further questions, it's just